Colorectal cancer is thought to be the most preventable cancer. However, it kills over 50,000 people annually, making it the second biggest cancer killer in the U.S. How can the disease be prevented, and what advances have been made in treatments? We'll talk about it on this episode of Real Science, Real Innovation. Thanks for watching this webinar from Barnes-Jewish Hospital in St. Louis. I'm Jason Merrill. Colorectal cancer is diagnosed annually in over 140,000 people a year. However, it's thought to be very preventable because screening can catch things very early. To tell us more about that is Dr. Dayna Early, who is a gastroenterologist with Washington University, Barnes-Jewish Hospital, and the Siteman Cancer Center. Dr. Early, thank you for joining us.
Thank you.
So how prevalent is colorectal cancer?
Colorectal cancer is a big issue in the United States. As you mentioned, it's one of the biggest killers in this country behind breast cancer and lung cancer. And one thing I want to stress is that I really think that colon cancer is completely preventable. I think we could essentially wipe it out if we can get people to really buy into colon cancer screening.
We're going to take your questions during this webinar. You can email us at barnesjewish@bjc.org, or you can tweet us a message via Twitter at barnesjewish. Twitter.com/BarnesJewish. Are you into Twitter, Dr. Early?
Not too much. No.
Okay. Me either. But. So, is there anything people can do in their diet or lifestyle to reduce the risk of colorectal cancer?
It's a great question. It's a question I get a lot from patients. The data about diet is really mixed. One thing that seems pretty consistent is that you should have a diet low in red meat. The fat associated with red meat seems to increase the risk. In terms of the fruits and vegetables, I always recommend a healthy diet. There's not real strong data that this changes your risk for colorectal cancer, but I think it's a good choice for your health overall.
Now, it's said colorectal cancer is the most preventable cancer. Why is that?
The reason is that with colorectal cancer, we have an easily identified precancerous lesion, and that's the colon polyp. And what makes it really exciting to do colon cancer screening is that when we can identify these polyps, we remove them and we essentially prevent a person from getting colon cancer. These are easy to detect, they're easy to remove, and they can really impact a person's lifetime risk of colorectal cancer.
Now, what are the screening tests a person should think of if they need to get screened for colorectal cancer?
It's interesting. Compared to other cancers, I think colorectal cancer, if, for example, you look at Siteman's website or American Cancer Society website, there's kind of what we call a menu of options. You can do colonoscopy, which is really the one I advocate most, and I'll tell you why in a second. There are several different types of fecal tests that can be done. You can look for traces of blood. There are actually tests that are being developed and will soon be commercially available. We'll look for DNA in the shed colon cells in the feces that can show us any genetic mutations. Sigmoidoscopy is similar to colonoscopy, but only looks at a small portion of the colon. So it's really kind of fallen out of favor because it doesn't look at the whole colon. And then CT colonography, or what a lot of people hear of as virtual colonoscopy, is another option. I'm really a big advocate of colonoscopy, and that's the way I'm going to go when I get my first colon cancer screening. And the reason is that we can look at the whole colon, we can easily identify polyps, and we take them out right then.
Talk about the procedure. How does the whole thing work?
Well, there's no question that for the patient, the worst part is the fact that they have to clean out their colon. But that part is really crucial because the cleaner the colon is, the more likely we are to find the small polyps. And even the small polyps could potentially be precancerous. So we want to find them all and get them all out. So taking a laxative the day before the test is very important, but not particularly pleasant. There are some laxatives that now are available. They're a lot less volume, and people tend to tolerate them better. And then the patients come in fasting that morning with a family member or friend, and an IV is inserted so that they can get sedative medication. And generally, they don't remember much after that. We sedate them, we do the procedure, we take out the polyps, all while they're sedated or sometimes even completely asleep. They recover for 30 minutes and then they go home and can go back to their regular diet. The only restrictions are from the sedation. They have to kind of take it easy that day, but the next day they just go back to their regular diet and routine.
Okay. So if a polyp is found, there are two types of polyps, correct? What is the different path you would go down if you found a polyp?
So we use our pathologist to help us with this, and they determine if a polyp is hyperplastic, which most hyperplastic polyps, with a few exceptions, are not considered precancerous. And so we consider that person's risk the same for colon cancer as if they'd not had a polyp at all. The adenomatous polyps are the ones that are considered precancerous, and there's some features about them that let us know if a person's risk is slightly increased, markedly increased. It's the size and some of the features that we see under the microscope. So at the present time, we like to take out any polyps that we find, send them to the pathologist to look at, and then make a determination about that patient's risk for future polyps and recommend the surveillance, their next colonoscopy based on that.
So if the more serious polyp is found, a person would then come back for a colonoscopy more often?
That's right. So if the polyp is at least 1 centimeter, which is about 1/2 inch, or has some features under the microscope that make it look more precancerous, we would generally follow them up in 3 years. And if that test is normal, every 5 years. For somebody that has a normal colonoscopy and they don't have any risk factors, the recommendation is a colonoscopy every 10 years.
Okay.
So it's not too hard to comply with.
All right. Now, you talked about the prep earlier. That's the one complaint that many people have. Have there been improvements in the prep over the past few years?
There are improvements. As I mentioned, one of the improvements is that companies have come up with smaller volume preps so the patient doesn't have to drink as much. And they've tried to improve the taste of them. One of the preps that we use is mixed with Gatorade. They've tried to flavor them some. But we still have to do something to really clean out the colon. There's no way around it. So I don't think that's going to go anywhere anytime soon.
Yeah. One of your colleagues once said, it's one rough night, but it can save your life. And that's kind of the message that you would agree with.
I think that's completely true. I mean, it's much less invasive than having cancer and all that you have to go through when you have colon cancer. It's much easier to prevent it.
So at what age should a person start thinking about getting a colonoscopy?
So for somebody that we consider average risk, so they're at least 50, they have no risk factors for colon cancer, they have no family members that have had colon cancer, their average risk, we recommend starting at age 50, and if they do colonoscopy every 10 years if they don't have any polyps.
Okay. And when is a person deemed at high risk?
So there's several factors that increase a person's risk, and it's a little bit of a heterogeneous kind of issue, but family history is the most common for sure. And the greatest risk is if a patient has a first-degree family member. So that's either one of your parents, any of your brothers or sisters, or any of your children, actually, that have ever had colon polyps that are precancerous or colon cancer. Those people are at increased risk and should probably start screening at a younger age 40, maybe 45. Depending on how significant the family history is, we'll make recommendations either 5 to 10 years if they don't have any polyps. There are a few very rare genetic syndromes that really increase an individual's risk for cancer, and we start screening those individuals much younger, sometimes even in their teens and 20s, and screen them every 1 to 2 years. Again, those account for probably less than 5% of colorectal cancers.
Okay. So let's say a person gets a colonoscopy and you do find colon cancer or colorectal cancer. What happens then? What's the next step?
Well, the next step is that we do a screening or a staging evaluation. We do a CAT scan to see if there's any evidence of spread outside the colon. If there's not, the next step is surgery. And I think we have very good success curing early stage cancers with surgery.
Yeah, and surgery's come a long way. I know many years ago it was a big open procedure, but now there are a lot of laparoscopic options at hand, right?
The colorectal surgeons at Siteman Cancer Center were one of the group that really pioneered laparoscopic-assisted colon resections for cancer. And one of the big differences that they've noticed, they get just as much tissue out as they need for a cancer resection. The patients recover just as well, if not faster. One of the big differences, though, is that the patients get less scar tissue in their abdomen, so their risk of trouble with bowel obstructions down the line is much, much less.
Right. And these are just 4 tiny incisions about that big that they make in the body to get the instruments in instead of a big open surgery, right?
That's right. Tiny incisions. Almost all of the dissection is done with these tiny instruments. They often have to widen one of the incisions to physically get the colon specimen out, but it's still a very small incision compared to a standard procedure.
Yeah. Is there a time when surgery is not an option?
We almost always try to resect colon cancers when we can. If a patient has widespread disease, it may not be in their best interest, but it's something that we think of in virtually every patient with a newly diagnosed colon cancer.
Okay. We do have some questions, and again, we're wrapping up, but we can take your questions at email us at barnesjewish@bjc.org or send us a note through Twitter at barnesjewish. One of the questions we have from Kathy H. in South City is, do you have to get knocked out for a colonoscopy?
Well, you don't have to. That's certainly most people's preference. It can be uncomfortable because of the air that we put in to be able to see and because there are twists and turns to the colon. But it's really an individual's choice whether they want to be sedated or not.
And we have some other questions here that have come in. I smoke and I'm trying to quit. This is from Bob in Dardine Prairie. I smoke and I'm trying to quit. Am I at risk for colon cancer? If I quit, does my risk go down?
It's not really clear if your risk goes down. Probably your risk is a little bit elevated because of tobacco use. No one has changed the recommendations in terms of screening earlier or more frequent for smokers, but I think certainly it's in your best interest for your overall health to quit smoking, so good luck to you.
All right. And he also asked, my wife is overweight, how about her?
Well, that's a great question. There is a lot of data looking at that, particularly patients that have type 2 diabetes and what we call insulin resistance. So their cells are resistant to insulin, and insulin is actually a growth factor. So patients that are insulin resistant are at increased risk for getting colon cancer. And we've actually done a study looking at diabetics compared to non-diabetics, and they're more likely to get colon polyps. And particularly obese diabetics as compared to lean non-diabetics have a really increased risk of getting colon polyps.
Okay. We have a Twitter note from Jan. Do colon cleansers help prevent colon cancer?
There's no data about that. Essentially what your colon does when it produces a bowel movement is cleanses your colon. The colon is not sterile to begin with, so I don't think colon cleansers improve colon health. There's no data to show that. And there's no data to show that it reduces cancer risk.
Okay. So overall, what's the message you want to get out about colorectal cancer?
Well, there's a few myths about colorectal cancer and screening, I think, that need to be addressed. And one of the most important one is a lot of people say, I feel fine, I don't need to be screened. Well, that's exactly when you need to be screened. When you feel fine is when you have a polyp or maybe even a small cancer. If you wait till you have belly pain or bleeding or changes in your stool and it's from a cancer, it's definitely going to be more advanced. So when you feel good and you're healthy is the exact right time to get screened, because if you have any lesions like polyps, we're going to take them out while you're asymptomatic and prevent you from getting colon cancer.
Okay. Dr. Early, thank you for your time.
Thank you, Jason.
That's it for this episode of Real Science and Real Innovation. For the full list, visit our website, www.barnesjewish.org. We have archives and a schedule of future episodes. Thanks for watching. Until next time, I'm Jason Merrill.